That's what led to me creating Visionera today, is to really kind of act as the translator between the DME company and the kind of service and offerings that they're providing, and translating that into keywords that the health plan can understand.
Your work literally shapes capitation models and payer strategies across Texas. What's like a misconception DME owners still have about payers?
I think one of the misconceptions that they have about payers is what their goals are, and maybe not understanding sort of the big data that payers are able to see to understand total cost of care.
Speaking of Medicare and additional payers, Medicare Advantage is exploding. How does that change the DME payer relationship?
I think it actually makes the payer strategy and payer development even more important, because Medicare is any willing provider. As long as we meet the qualifications, we're able to get in, whereas Medicare Advantage, a lot of those networks are closed. So it kind of even shifts us more into this position where we need a really solid payer strategy and really solid payer development. The mindset shift for new market participants would be, how can I differentiate myself to be able to not only improve patient outcomes, but to be able to show the health plan that we're needed in the network.
All right, we are live. Welcome back to the #1 DME podcast in the country, claim to fame. Today we have Heather Davis from Visionera. Welcome to the show, Heather.
Thanks, Alex. Really appreciate you having me on.
Yep. Welcome, Heather. Thanks for the time.
Thank you.
So, yeah, we always like to start off by kind of just finding out a little bit more about you. So who is Heather Davis and what does Visionera do?
Sure. So Heather Davis, I've been in DME for 20 years. I'd been a COO at a couple different DME companies and had already started really creating strategies around payer contracts, value-based care, and working really closely with the state and kind of understanding the interplay between the state, between the health plans, and between the provider. But then I also interestingly worked for a health plan, managing a provider contracting team out of Southern California. And that was kind of after my DME days. And that was very eye-opening for me to really understand the challenges that the payers were facing and what kind of keywords and programs that they needed to see from DME companies. So that's what led to me creating Visionera today, is to really kind of act as the translator between the DME company and the kind of service and offerings that they're providing, and translating that into keywords that the health plan can understand and really get a sense of why it's important to allow DME providers into the network.
That's awesome. Thanks for sharing, Heather. Excited to dive deeper into all of this. Most DME companies and folks avoid payer contracting like it's the plague, but you've built an entire career loving the complexity of it. What sparked all this?
I think what sparked all of it was seeing the kind of innovative programs that I've been able to create for patients and measuring those outcomes, and just really seeing how there's different ways to solve the problem. Like, a lot of times I say it's not as simple as paying the provider less, and it's not as simple as paying the provider more. There's a significant problem with the cost of healthcare in this country, and really in order to fix it, we all have to come together in ways that are more innovative. And so as I started to enter into value-based care arrangements and see how I was able to create wins for the provider, the patient, and the health plan, it drove me towards a mission of real solutions that really end up deeply impacting patients. I've saved a tremendous amount of falls and skin breakdown and UTIs, all sorts of hospitalization reductions that I feel really proud about, and I want to spread that over the country. And that's really why I'm here, is to create innovation within the DME market that ultimately impacts patients and allows DME companies to grow their revenue.
Your work has literally shaped capitation models and payer strategies across Texas. What's like a misconception DME owners still have about payers?
I think a misconception that they have about payers is, let me think about that one, because there's so many misconceptions. I think one of the misconceptions that they have about payers is what their goals are, and maybe not understanding sort of the big data that payers are able to see to understand total cost of care. providers, by their very nature, we only have so much information about a patient and about the claims that are going out, but the health insurance company is really able to see the bigger picture and understand how things impact total cost of care. So I think there's a real opportunity for providers to start viewing from that same lens and come to the health plan with programs that do ultimately drive down total cost of care, even improving upon like the existing network. How can we make outcomes better for people?
That's really interesting. We always like to look through the lens of the provider, and many of these DMEs, that I would say struggle with this, right? There's a lot of unknowns. What are some small things they can fix immediately in this world?
I think some of the small things that they can fix immediately, it's interesting that you ask that, because a lot of times when I talk about value-based care, I talk about how you don't need to make huge improvements in outcomes. It can really just be small programs that they're putting in place. A big gap that I see or opportunity today is around patient education. It's always been important. I think accreditation allows you to kind of hand out a user manual for patient education. And that may work for some people, but it's not going to work for a lot of patients. We have different people with different needs. And on top of that, the equipment, devices, and things that are going into the home are smarter than ever. We're getting really smart devices in the home that people need a lot of support with that. So what I think providers can do today is to think about how they can ramp up or improve their patient education programs. And then even like, how can we do that in small pilots for the small number of patients and just kind of measure and survey those patients and see how they're doing. I think sometimes providers are kind of afraid to do that because in their mind, there's a little nervousness that maybe they're not making an impact. But every time I've seen a provider put together a program and measure the outcome, because people don't have those kind of programs today, it's really incredible how much improvement we're able to make in people's health. Because what we say in DME all the time about DME being really essential to reducing rehospitalizations is absolutely true. But what's also true is that we still have a lot of room to improve on that.
Heather, along the lines of measuring this, what KPIs really matter to payers, but most DMEs ignore? What should they actually be tracking?
They should be tracking. I think they should be tracking. It's not just what they're tracking. It's how they're designing their programs and how they apply those resources out. So it's whenever we're looking at patients and trying to support them and give them education, it's important to realize that different populations, different people are more at risk than others. There's going to be people with certain comorbidities that we want to really follow up and make sure that they're using the equipment that we delivered. But as far as what they're tracking, nothing beats reducing total cost of care. I mean, that's kind of pie in the sky if you can reach that. That's not always absolutely possible, but they definitely like to see reduced hospitalizations, particularly around specific comorbidities or really specific populations, because this is how the health plans think. Their medical directors are not just there to process and or deny authorizations. They're there to set the clinical direction for the health plan, and they have so much data about where the highest risk and most complex patients are. So we want providers to start thinking about, how do I find those patients out of my population that are really most at risk and assisting them. I think delivery time does matter and patient satisfaction does matter, but ultimately those are inputs, and what the health plan is really thinking is in terms of outputs. How does this impact total cost of care, and is this improving upon the current provider network that they have?
Heather, if you were designing like the perfect payer DME partnership playbook, what would the first 3 rules be?
The playbook, designing the program, designing the playbook. Number one and most important is when we design the playbook and when we approach health plans with that playbook is that it's in the spirit of collaboration, that we're approaching a party who also has challenges that they're facing. So we want it to be designed in a way that's collaborative and presented collaboratively to the health plan. So doing some research on what's their challenges and what's happening in their world. The other thing I would say is define a specific population. who is it that you're going to impact and how are you going to do that? So it's not just defining a really broad population. I'm not one to go in and tell the health plan I'm going to be an expert and improve outcomes in 15 different product categories. I would design a program that's really focused on one product category that I know I can improve outcomes and really show expertise. The third thing, and probably really, this may potentially be the most important, is offering a contract that puts you at some level of risk. And it's interesting, that word risk is scary, right? But the way that the health plans are paid is on a per member per month basis. So similar to how you pay a premium every month for your insurance, the state and the government does the same thing to the health plans. And so they have to manage all of the cost and they're at risk. If the cost goes over, they lose that money. If the cost goes under, they keep it up to a certain percent. So what I found really fascinating is you could walk into a provider contracting person and say, I'll give you a 10% discount. And it's, maybe. But if you walk in and you offer a value-based contract and you're willing to take up to 10% risk, now you have their interest. They hear that word risk, it's like light bulbs, like, oh, they're aligned with me. They're taking on some of this risk that I'm having. And then it works great for the provider because you were maybe going to take that 10% anyways to get the contract, but now instead, you not only have a chance to not take that 10%, but then even make it up more, because usually what I always recommend is taking some risk, but then also having an upside as well. So maybe you lose 10% of your revenue that year from performance, or maybe you gain an extra 10%. It's all about how you design it and what kind of risk level you're comfortable with.
Heather, you're obviously extremely knowledgeable with the payers, and I feel like you could have gone into any healthcare segment, but you chose to build Visionera for DME companies. What problems did you feel weren't being solved, or kind of how do you fit into what they're doing?
My purpose and mission is to drive value-based care. So my company, we do a lot of expansion work, a lot of standard kind of payer contracting. We're really good at coming up with strategies to get in network. But my mission is about value-based care because we're kind of behind on that innovation in our industry. This has already been rolled out in a lot of other areas of healthcare. There's a lot of different provider types that are tracking data. And what's happened with them is eventually those other sectors, value-based care has been forced upon them. The health plans design the program and the providers don't love it, or it doesn't really totally account for what's happening in their world. And so now is the time, in my mind, to design those programs for DMEs. We don't want to wait for the payers to do it. They don't understand DME and they can't do it. So at the end of the day, to me, it's behind value-based care is still all about driving the patient outcomes. It's really shifting people from always thinking about like, we're not serving a customer, we are serving a patient. And at the end of the day, it's all about their health outcomes. And what value-based care does is it gives payers and regulators an alternative to fee schedule reductions. Right now, we as an industry haven't really given an alternative to fee schedule reductions. So that's the first place they're going to go. Consolidate, limit the network, bring the rates down, reduce the fee schedule, because it's the only viable option that they have. Even sitting as a DME company, it can be hard to think about how we can change that narrative, which makes me realize it's darn near impossible for a payer to figure this out for us. And there's so much opportunity to keep people out of the hospital. It's really meaningful to me, the amount of hospitalization reductions that I've measured at DME companies where we've implemented programs like this.
That's awesome.
Yeah. And I think one thing I've seen too is payers and regulators are continuing to show us that they're moving towards the same direction of limiting the providers and reducing the fee schedule. Sometimes we're able to slow that down. The industry is able to get a win here or get a win there. But if we look at what's been happening, at least for me over the last 20 years, seeing what's happening in DME, everything kind of keeps heading in the same direction. we'll kick competitive bidding back for a round or two, and then they throw out this new rule, and it's more limiting than the previous rounds even. And we see that more and more networks are getting closed. So I think what that is showing us from the payer side right now is the strategy that we're using isn't totally stopping the shift. We need something else to kind of become a part of that shift and give them an alternative.
Heather, you're uniquely good at making a DME payer ready. What's a transformation look like to make a DME payer ready?
To be payer ready is to shift. I'm thinking about how to answer this, because there's payer ready as far as like just getting into the networks that you can and kind of finding open networks and making appeals to them. That's one area. Then there's another area of preparing a DME to be able to get big wins, like national contracts that really drive like a lot of revenue to them. So for me to get a DME company payer ready, just to kind of get your standard in-network contract, a lot of times that just boils down to me translating the message of what the DME provider is already offering and why that's so essential to the network. Now, getting a DME company ready to actually like gain substantial market share from their payer relationships and really improve outcomes, that is more than just a translation. That is helping them transform their culture really from top to bottom and making sure everyone understands that we are dealing with patients, we're not dealing with customers, and changing the things that we measure. If they're just customers, we might measure how quickly they're answering the phone, or how fast we get the delivery out, or how many voicemails we return. But when we think about we're dealing with patients, we can start really measuring and thinking about clinical outcomes too. So it's a change from top to bottom. It goes all the way through billing, through customer service, and it changes how we interact with people. And again, I think a lot of it right now, the opportunity is in patient education and how we can improve that. DMEs only have so much an opportunity, and I think they're already thinking about delivery times and response times and things like that. So the missing piece is the education.
Heather, what's the biggest regulatory or policy shift coming to DMEs that they should prepare for now?
I think the biggest regulatory shift for DMEs, I mean, I can't ignore the elephant in the room, the Medicare competitive bid announcement. I think we were, supposed to hear back on that sometime this month. What definitely caught my eye on that was Medicare's intention to choose and select only either some national providers for the dropship categories or choosing regional providers. That's important to me because it tells me if I'm at a DME company, it's time to expand, because the payers are telling us that I can't sugarcoat it any other way. The payers are just telling us they don't want to manage this many contracts, that they want to have fewer providers. And we know that creates an access issue, but we've only seen Medicare get stronger and stronger in this with the other plans following suit. So if I could suggest something today, I would say to try to expand your territory. It's going to not only help with a potential Medicare competitive bid in the future, but also help you get into more health plans today. And I would really just encourage people to continue to think about how they can impact outcomes and measure those outcomes, because that allows us to create a much stronger argument to Medicare. Like, for example, right now, we're not able to, I think, advocate as strongly as we could around a quality component, because Medicare is not able to look and compare providers based on quality. They kind of lean on accreditation, which doesn't actually give a quality measure or really a report card. It just all kind of tells us that we're meeting the minimum standards.
Yeah, it's obviously something that's on top of everyone's mind right now, and it's tough to try to prepare for something like that. And it's easy to say expand, but how do you do that if you're kind of a smaller shop and trying to survive? What advice would you give to somebody, and how do you prepare for that over the next few years?
I think how to prepare for that over the next few years, let's say they're a local shop, I would still, if they're really defined to a local area, then I would recommend just trying to really focus on outcomes. there may not be a magic wand for Medicare for those folks if they choose to continue the route they're going. But folks that are smaller shops or maybe in rural areas, I think if they really focus on performance and focus on creating programs and measuring things that the payer thinks is important, and they can at least build those local contracts and those local presence. Because a lot of times local providers even still may be shut out of 50% of even their local networks. And so if they can really get those down, it can cushion and protect their revenue, where ultimately if that Medicare revenue is lost, at least they're able to capture more of the payers that are actually in their area.
Heather, speaking of Medicare and additional payers, Medicare Advantage is exploding. How does that change the DME payer relationship?
I think it actually makes the payer strategy and payer development even more important, because Medicare isn't any willing provider. As long as we meet the qualifications, we're able to get in, whereas Medicare Advantage, a lot of those networks are closed. So it kind of even shifts us more into this position where we need a really solid payer strategy and really solid payer development. And it's always keeping in mind that a DME company has multiple customers. It's not just our patient, and it's actually not just our referral source either. It's also the health plan. That is a customer that we have to create messaging for, market towards, and build long-term relationships with.
You've called DME complex and intimidating. There's no doubt about that. What's the mindset shift needed for new market participants?
Oh, the mindset shift for new market participants would be, how can I differentiate myself to be able to not only improve patient outcomes, but to be able to show the health plan that we're needed in the network. Because that's the barrier that they're going to run up against once they get started and once they start applying for contracts, is the health plan's going to say, we have 100 of you already. So how do we think about, how do we make it so that we're not the same as every provider? And I don't mean to suggest that we are, but health plans really just see us as product shippers, as dropping product into a box. So how do we create programs to differentiate ourselves? And then how do we communicate that to the health plans?
Heather, you've worked, in your career in many different formats, right? So you've been working with startups, PE-backed, major organizations. How did each shape your approach to strategy?
It's an interesting question, because what I've seen as far as being able to move into creating a new payer strategy is that small and medium-sized companies seem more able to shift into that, because that's the way that sort of any change management works, right? Is that in order to get a shift in your strategy or how you're thinking about things, it's just a bit easier to do when it's a smaller company. And I think smaller companies really have an opportunity to improve on their service more easily. Not that they're not giving good service today, but I think that a lot of times referral sources can feel like they can call and somebody's going to answer the phone, that they can actually reach someone. So while I do think companies of all sizes have the opportunity to go into value-based care and into thinking differently about how we contract with insurance companies, I think that it's almost like the smaller they are, the faster they're able to pivot into something new. It's because also once you've gotten your revenue up to a certain point, it's harder to understand why a shift might be necessary and why it's actually worth the resources and investment to put in these kinds of programs. Because there is an investment of resources by the DME provider to create these programs that go above and beyond the minimum. But that's the purpose of value-based care for DME and really for every other industry, is that when we create those programs and they do well, we're able to recover the funds through the value-based contract that covers the cost of what we've put in. So there has to be almost enough like need within the company to really want to kind of seize that opportunity and drive a lot more revenue from the payers.
Heather, I feel like you're very forward thinking and, have a lot of insight into the direction things are going and how to help providers succeed. What is your prediction for the DME landscape, let's say by 2030?
DME landscape by 2030, I think we're going to see more and more DME providers entering into capitation and value-based contracts. Right now, they're doing that without much competition because other providers don't really know what's going on behind the scenes. Like when an exclusive provider arrangement comes out, they don't really have the exposure to understand like why or how that happened. Now I'm seeing a lot of increased attention in value-based care. And so I think over the next 5 years, we're going to continue to see a lot more programs roll out. Not just like these large ones that cover a ton of product categories, which I'm not really an advocate for. I think we're going to see more like truly successful clinical programs roll out like at a more local level. I think meanwhile, the payers are going to unfortunately continue to do what they've been doing as far as closing networks and trying to limit the number of providers. But I think this industry has a lot of innovators. And so there are going to be people that see that not only as a death sentence, but also as an opportunity. And that's something I'm always looking out for our clients is these shifts that the government's making or that health plans are making. They do sometimes create opportunities, not just in like when we're thinking about how they change our fee schedule or stuff with us, but just things that are changing at the health plan level when they implement new service coordinators or they're basically case managers or some kind of regulation comes into play. Like, for example, a state will come in and say, hey, we want you to have X% of your contracts to your health plan. We want them X% to be in value-based care by this date, and we want this percent to have risk. So when I follow things like that, then I'm able to go to providers and say, hey, this is a state right now. I would try to go in value-based care, and let's make sure that we mention risk. And let's also make sure we mention your rural coverage because I see that that's also important for the health plans. The health plans are forcing us into more innovation, even if we don't totally realize it. So I think these next 5 years, especially the next 10 years, are going to be won by the providers that are innovating and are following the path of the health plan. We still always want to fight back. We always want that in our toolbox, but we don't want that to be the only tool in our toolbox.
That's insightful. Heather, to kind of finish up my last question here, where do you see Visionera in the next 5 years?
Where do I see Visionera in the next 5 years? I would love us to... Where do I see Visionera in the next 5 years? I see us being a driving force behind this trend and shift to value-based care. And I see us continuing to drive the reduction in thousands of hospitalizations. We've done it already. And that feels really good, literally, just to go to sleep at night and think about thousands of people who didn't go to the hospital, whose family didn't have to visit them in the hospital. The numbers are kind of astonishing. But I also see Visionera continuing the work of even, without value-based care. We do tons of work. Probably 80% of our work is not in value-based care and is really just around crafting the right messaging for people and identifying the right payer targets to kind of get them in network and expand their revenue. So I see Visionera being the main go-to for people that want to expand their DME companies, want to get into new states, and want to break into new networks. And then I also see us as being the go-to for value-based care for folks that want to really use this to create really substantial revenue and just have a lasting kind of legacy on changing patient outcomes.
That's great. Wow. Well, our listeners are going to have a lot to listen to on this one. There's been a lot of great information, and this has been super solid. The way we usually end out every podcast episode, we do a rapid fire, sort of like a this or that. We can start whenever you're ready.
Sure.
All right, let's do it. Okay. Coffee to survive contracting meetings or wine to recover from them?
Wine to recover.
I like that. If payers had a theme song, would it be Complicated or Don't Stop Believing?
Like, which Complicated? I'm trying to think of the song that even is.
Complicated.
I would say Complicated.
Okay.
If we're honest with ourselves, the health plan is dealing with a really complex problem in healthcare in the country.
What's more terrifying, a denied contract or a surprise accreditation visit?
Depends if there's somebody at the office when the accreditor stops by. Closed network isn't very scary to me, so I'd say it's a surprise accreditation visit. Make sure you have someone at the office 30 hours a week on your posted hours. It's a real showstopper when that doesn't happen.
There you go.
Then
Power
follow.
move. Early morning meetings or late night work sessions?
Early morning meetings.
Okay, last one. One superpower. Unlimited payer leverage or eliminating all documentation errors?
I mean, I like to blend those together, actually. There's some great tech tools out there that you can show payers how you can save them money on audits and stuff like that through some of the tech tools that we have. And now I've forgotten your actual original question. 'Cause I got to thinking too deeply.
Unlimited payer leverage or eliminating all documentation errors?
Oh, eliminating payer leverage? Is that what you said?
Unlimited.
Unlimited payer leverage or eliminating all documentation errors?
Unlimited payer leverage.
There you go. Well, Heather, this has been an awesome episode. If anyone wants to reach out to you or find out more information about what Visionera does, how can they contact you?
So our website is www.visionera.net. And my email address is heather@visionera.net.
Awesome. Well, Heather, thanks so much for joining. And for our listeners, if you have not yet subscribed to the Claim to Fame podcast, please do. Thanks again for joining. This has been great.
Thank you. I really
Thanks, Heather.